Thrive Tribe are a healthy lifestyles services provider, and we specialise in running health and wellbeing programs across the country, really. We're 17 years old, so we've been going since the start, really, when public health became a department and everything got separated out from the primary care trusts. Tim, our CEO and founder, at that point, he was running a stop smoking contract or a stop smoking service for the NHS. He got told that he'd no longer be NHS, he'd be working for the council and they'd be going out for a procurement process, and he set up Thrive Tribe. It wasn't called Thrive Tribe at that point, but he set up the business and we've grown from that. We have quite a lofty ambition as a health and lifestyle service provider. We want to help over 1 million people change their behaviours and thrive. It's not some arbitrary number. We actively measure our progress against that. We're about a third of the way there at the minute. We've helped about 330,000 people directly make health changes in that 17 years. Helped well over 100,000 people give up smoking. We've helped over 50,000 people through an NHS health check. We've helped 60,000 people lose weight. And in the last couple of years, we've also been delivering NHS services under the Healthy You brand. Healthier You brand. In that time, we've helped probably about 35,000, maybe 40,000 people so far through a NDPP provided program. Cheers, Teddy. So just on that, so we've been a provider of Healthier You services since Framework 3 kicked in, which was the start of 2023. We're kind of the new kids on the block. I mean, I don't feel like we can really say that when we're 2.5 years in, but we were the only new provider that joined at Framework 3, and we're one of 4 providers available to ICBs or working with ICBs nationally to deliver the NDPP programme on behalf of NHS England. You can see our 7 ICB areas there, and I'm, as I said, pleased to say there's representatives of 4 of those on this webinar. We are in the process of mobilising and launching 2 new programmes for NHS England as part of the Healthier You brand. There is what's called the long-term condition prevention pilot that we're not really going to touch on today, but is running across a few ICBs nationally, and that's focused on using an NDPP-like intervention to help people with who have hypertension outside of NDH. The big one that we're here to talk about today really is the behavioural support for obesity prescribing programme, which is obviously brand new and that we're setting up at the moment. A little bit on content of today. We covered this mainly, but most of this will be led by, or the first half of this will be led by Richard, going through the importance of behavioural support alongside prescribing and patients taking Tirzepatide or other GLP-1 drugs. After that, we touch on what the programme is and what our offer looks like to patients who are referred to us for that behavioural support, as well as Chris and Bex going into the content and how it differs from our core NDPP programme. I'll then finish off at the end with a little bit on the eligibility for the programme, but also how anyone on this call or working across those 7 ICBs could refer a patient to us. And equally, we'll answer any questions at the end, so please do use chat. Cool. Richard, you're up.
Thank you, Jimmy. Welcome again, everyone. Thank you for giving up some of your lunchtime to be here. Hopefully this will be educational and maybe even entertaining. As I said before, I'm a GP partner and lifestyle medicine physician, and today we're going to talk not about how the drugs work, which is, a slightly different conversation. Indeed, many of you probably know anyway, but we're talking about the wraparound care for Tirzepatide or Mounjaro in primary care, which as of officially the end of June, has been something that patients are meant to be able to access. You will know as well as I do as a GP, depending on how many GPs on the calls, that it's really helpful when policy gets announced by a news headline and emails get sent out. And many of you, many people like me actually don't have a service set up by our ICB yet. They're talking about it. They're saying it's going to happen. So you're actually one of the fortunate few who actually have this service set up in terms of the wraparound care. And presumably within your ICBs, there are conversations going on about federations, PCNs, etc., people who might be providing the actual medical service per se. Could I have the next slide, please? So as the slide asked the question, why bother with wraparound care when you've got a miracle drug? And it's fair to say, let's be honest, these drugs are impressive. In my time, I'm 52 years of age, there have been quite a few drugs that have been promised. Before my time, it was sort of amphetamines and various other appetite suppressants. Then we've had sibutramine, orlistat, and now drugs like semaglutide and now tirzepatide. And in the pipeline in the next few years, there are apparently loads more. They're going to be even better. They're going to be oral medications instead of injections. But today we're talking about tirzepatide, which does have pretty impressive stats. It's thought that in the trial data, and we'll get onto the issues around that in a moment, that maybe people could be losing 20-25% of their weight, of their body weight. And the next generations of drugs are predicted maybe to be 25-30%. So if this drug truly is miraculous, why should we bother with wraparound care? Next slide, please. Well, the answer is that it's not all that straightforward, is it? As we all know. We're going to talk about the importance of behavioural support, etc., in a moment. But let's be honest, these drugs have limitations. They have side effects. There are high discontinuation rates. In some trial data, it's been up to 50% at a year. So unless people are supported in the right way, they may not even be able to, they may not wish to continue taking the medication. And we know, as those of us on the call today who are doctors, that the World Health Organization stats about adherence and how many people are taking their regular medications once they've been put on them are shockingly low. You could argue that if you just have to inject yourself once a week and you're getting a huge benefit from it, maybe adherence could be better, but it's still an issue. And the other thing to think about with these drugs as well is that there isn't any long-term data for safety or efficacy. Well, in fact, all we know so far is that if you stop them after a couple of years, that most people put most of the weight back on in fairly short order. So this is again why the wraparound care is important, which I'll talk about in just a moment. We should also bear in mind that real world outcomes are never as good as trial outcomes, because obviously in a trial, you've been recruited, you've got a particular reason for being there, whether it's altruism, whether it's because you're getting paid or whatever. And real world outcomes are never the same as the outcomes that you get from a study. And also we need to bear in mind as well that these drugs they don't address root causes, which is what we're interested in as Thrive Tribe. They are a symptom. Weight is a symptom. Being obese is a symptom of all the things that have happened in your life, whether it's adverse childhood experiences and mental health issues that arise from that, poor nutrition, lack of education, living in a toxic place, in the middle of a food desert, being less active, having a difficult relationship with food. Those are the root causes, and these are merely drugs that address the symptom at the end of it. And in the same way that taking paracetamol for your knee pain helps to address a symptom, but it doesn't address the underlying cause. This is why wraparound care is particularly important if you want sustained change. And weight regain off the drugs, as I've already mentioned, is common, rapid and substantial. We think that maybe less than 17% are maintaining weight loss a year after stopping. Now, some of you might be thinking, but we know realistically that these drugs are going to be taken for the rest of a person's life if they can tolerate them. And you might be right. But the question is how much better and healthier people might be if they get the right support. Next slide, please. And this table here demonstrates just how important that behaviour change support is. We know that if you do get behavioural support, you are less likely to regain as much weight after stopping the medication, which at the moment is what everyone is meant to do. We know that you are more likely to maintain long-term maintenance in that respect in terms of the weight, and also that there is some evidence for improved psychological resilience as well, less vulnerability to relapse, more likely to be able to sustain changes. Next slide, please. And psychological support is really important as well. I've talked about people's relationship with food. It used to be the case that to become really, really, really overweight, morbidly obese, takes a huge amount of effort. It doesn't happen overnight, and it's usually because of significant underlying health issues and often pain and addiction. Sadly, nowadays, the world in which we live is that it's actually becoming easier to become obese, perhaps without all that trauma to start with. But the reality is that once you become obese, of course, you get a lot of physical and mental health problems that come with that. That's why psychological support is important. And I've often talked to people in the past whether it's to patients or to groups of doctors when I'm training them, that if a person is going to address their weight and living healthy in the longer term, often that mental work, that work on yourself, it should actually be done first to address root causes. Now, of course, in reality, that's not what's happening here. People who've got a BMI over 40, who have the additional full comorbidities, will simply be offered the drug, and it's important, therefore, not to neglect that side of the work. It's also worth bearing in mind that being in a relationship with other people, whether it's individually or in groups, is good to motivate you. It's good to help make you accountable to others. And we know, looking at the principles of behaviour change, you're more likely to succeed if you have those bits going on as well. Next slide, please. And a rounded and holistic approach is really important. These are my pillars of well-being. They differ slightly from the British Society of Lifestyle Medicine's pillars of well-being, but there's a huge amount of overlap. I list them as purpose, sleep, connections, movement, managing stress, and eating well. And I've run courses previously for patients in and out of my NHS role where we actually haven't talked about weight. We don't lecture people. We don't check their blood pressure when they come in. We don't make them stand on scales. We thought that would probably be counterproductive. But actually, by talking about these different aspects of their lives over a number of weeks, looking at the information, asking them questions, getting them to learn from and discuss things with each other, people had really improved health outcomes, even though the conversation about weight was not the primary focus, because we were treating them as humans, as whole people. And that was the feedback that we got consistently. That was what they liked. And people were dropping their HbA1c. On one course that me and my colleagues ran, 2/3 of people with pre-diabetes, a year after having done a 4-week course, had reversed their pre-diabetes. So that's really, really important. And the nutrition aspect is really important as well. Something that's come up since I first prepared this presentation, I read in the BMJ yesterday, written by a colleague of mine, Dr. Ellen Fallows, who works for the BSLM. They were talking about the real world dangers of malnutrition, because people are often malnourished to start with. The term overnourished has been used to describe obesity. I think that's a kind of revolting term, isn't it? Because it suggests that you've got too much good stuff going on. That's not the problem if you're obese. But people are often malnourished to start with. They're eating the calories, but not the right food. But then if you just simply switch to a drug which causes you to lose weight, including muscle mass, and you don't have the right support, and you aren't actually increasing the amount of protein that you eat, for example, there's a serious risk of malnourishment as a result. And I suspect we're going to get this data coming in more slowly over the next few years, a little bit like we saw the mental health fallout from COVID. There was immediate physical health issues and then the longer term complications. So we must be mindful of this, and that's why this rounded approach is important. Next slide, please. And this, I think, summarizes it all up. You'll be glad to hear that this is the last slide that you'll have to hear from me. This is evidence for the benefits of wraparound care. This is real trial data. The SURMOUNT-1 trial and the SURPASS-1 trial, they were both trials in patients of Tirzepatide. The SURMOUNT-1 had wraparound care, that's what we would call it nowadays, and SURPASS-1 had minimal lifestyle support. And as you'll see, at every single dose of Tirzepatide, from small to high, and including at the placebo level as well, those who were given the wraparound care has significantly improved weight loss in terms of their percentage weight loss. And you'll see that was particularly powerful for the smaller doses, which obviously were having less of an effect in terms of causing weight loss. So this, I think, is a really nice visual demonstration of what we're all about, what we're about as Thrive Tribe, what we're passionate about. And at this stage, I'm going to hand over to my colleagues to talk more about the service and how to access it.
Cool. Thanks, Richard. Yeah, really valuable presentation as always. And I know Richard's sticking around for about 10 minutes more. It's unlikely he'll be able to stay for the full Q&A at the end, but please do use chat if there's any questions for Richard. If they come in the next 10 minutes, you can hopefully respond in chat, Richard. But if not, we'll pass them on and we'll send over an email response from Richard in the foreseeable future. So yeah, please do utilize chat for any and all questions on either the clinical side of the drug or the behavioural support program that we'll be launching or have already launched in theory in all 7 of our ICB areas. So what is it? And it's called Behavioural Support for Obesity Prescribing, or BSOP. overall, which I think is it's not the most fun name. Wraparound care is what it's mainly referred to, either when we're talking to clinicians or probably the way that patients would understand the service as described to them. So what is it? So as Richard said, it's not long since NICE published guidance that Tirzepatide under the brand name Mounjaro would be suitable for prescription in primary care settings, only when also prescribed alongside a behavioural support programme. That put quite a lot of pressure on NHS England to quickly find a way to not just prescribe and sort out clinical management pathways for the prescription of Tirzepatide across all ICBs. They also had to then figure out this national model for providing behavioural support. Now, they're a bit tied given timelines and pressures on NHS England and usual procurement methodology, etc., on the best way to do that, because it needed to be done very quickly. So the way that NHS England approached it, behavioural support arm of the service, they already had contracts with 4 providers running 10-month behavioural support programs, but not for patients being prescribed Tirzepatide, but for patients with non-diabetic hypoglycemia as part of the NDPP program. So that kind of gave them their out. They came to Thrive Tribe and the other 3 NDPP providers to see if we'd be interested in offering the behavioural support program for those that are prescribed Tirzepatide in primary care, and doing that through a contract variation, which all took place very quickly. It was quite short notice. We were meant to be able to receive referrals from the 23rd of June. We didn't quite get the contract signed until about the 16th or 17th of June. So it was very, very short notice in how it worked. Now, that's all in place now, and we will be offering the interim solution for behavioural support for obesity prescribing, or BSOP. We will be offering that interim solution until at least the end of March 2026, and that's for patients starting. So if someone was to start the program on the 31st of March 2026, we would support them for the full 10 months. What happens beyond that is still a little bit up for debate, but I think it's highly likely that NHS England will find a similar interim solution, or perhaps an extension of the current one, so that it's aligned with what is happening with the NDPP frameworks and the re-procurement of that later next year. So I guess my point is we're definitely going to be around to help patients and start patients on the programme for at least 9 months, but I expect it will go beyond that as well. So what do patients get? So anyone that is referred from anyone who's attending today, or their colleagues in a local area, any patients would get access to a 10-month, 300-day behaviour change programme. Given the procurement methodology and the timescales that this was set up in, etc., the programme itself will look very similar to our NDPP programs. They're both 300 days long. They're both focused more so on behaviour change and supporting patients to make holistic lifestyle changes, like Richard talked through a minute ago, rather than direct clinical support with their health conditions, whether that's obesity, or whether that's pre-diabetes. It's available in different formats, or there's different pathways for the patients. So anyone who's referred and comes over to us, there's a degree of patient choice in what's best for them. In the behavioural support for obesity prescribing programme, there are 3 different options. One area it does differ slightly to regular NDPP is that in NDPP, we can't support patients through an online programme, but given that with the behavioural support for obesity prescribing programme, we're not sure how quickly referrals will come through. They're trickling in at the moment, and we don't want patients to wait around for too long. NHS England are allowing us to run online video programs that are accessible to patients from all different ICBs. So we've got staff here today from 4 different ICBs the nice thing is you can feel reassured that if you're the only surgery or PCN in your patch that refers the first few patients, they're not going to need to wait around for a long time to access a program. If those patients are happy to and able to access an online video program delivered through Microsoft Teams or Zoom on a tool like this, they can get started very quickly. Should referral numbers be adequate, though, we will be looking to run guided face-to-face behavioural support and obesity prescribing programs in the community. So the majority of our NDPP work is delivered in the community in person to service users. We will mirror that with this program should there be sufficient demand. And the final way patients can access this is a little bit more self-directed. So if patients don't want to spend time in a group setting engaging with other people and their peers, if there are patients who want to have it at their fingertips and access it whenever they want on their own terms, there is access to what's called Second Nature. They're the digital provider that we work with through our NDPP programs and our behavioural support for obesity prescribing programs. Patients in that, they do get access to a health coach who is a qualified nutritionist, but the engagement's a little bit more on their terms. So digital is a really popular pathway for this program, for NDPP. We're expecting the guided remote programs, so the online programs, to be a little bit more popular with this audience. But there are 3 different pathways available to any patient who comes to see us for BSOP. Cool. So there's a little bit of duplication, but in the right way, between a slide that I'm going to present here and one that will come from Chris and Bex later on. So NHS England identified kind of 2 sister services, if you like, as part of the overall rollout of Tirzepatide in primary care. So in each ICB area, there will be a clinical support service who do the prescribing of Tirzepatide and do the clinical management of the patient. So they'll monitor the impact on the comorbidities. They'll give personalized support for any side effects. They might look at titrating the drugs if necessary and monitoring dosage. They'll provide guidance on safe injecting and all that kind of more clinical element of using the Tirzepatide. And there's actually different models at play here. We've got representatives of 4 ICBs on the call, and some of those ICBs have different models. There's the kind of common element, which is that is all delivered either in a surgery or at a PCN level. But there are other ways of doing the clinical support nationally. And I know there's representatives of a couple of specialist weight management services, for example, who will be working with to provide the clinical support. Our offer as behavioural support for obesity prescribing provider in each of those ICB areas. The patients from every area will get the same offer. I just mentioned a little bit of that on the last page, but there's quite a clear delineation between what we do in an ICB area and what is delivered by the clinical support provider, whether that's someone working in a GP surgery or elsewhere. We will be running a long-term behaviour change program, which is available in different methods to the patient. We will give more generalized information on the impact of Tirzepatide on health, and some of our regular NDPP content is amended and changed to reflect either common side effects or common impacts of Tirzepatide usage on the patient. So the patient doesn't get the same program as our NDPP. It is tailored, and that's exactly what Chris and Bex will go into in a minute. But we don't overstep our boundaries. We don't touch on direct individual clinical management of the patient or the impact of Tirzepatide on their comorbidities, or in-depth detail on personal side effects. If that happens and the patient discusses that with our staff, we will signpost that patient back to the prescriber or their clinician, like a GP, for personalised guidance on that. And how that works. So one thing that is important is, should a patient, we want to encourage the patient to engage with both services, both the clinical management and obtaining their prescriptions and guidance on how to use the drug safely, and the behavioural support program that will be offered by Thrive Tribe as BSOP. We want to encourage engagement with both of those alongside each other as kind of sister services. And so we will update the prescriber through a surgery email or an alternative email if it's not through surgery that prescription comes, on the patient's progress at varying points of the program. So we will keep the prescriber in the know when we've received the referral. If we cancel the referral, and that is based on us attempting to make contact with a patient at least 3 times through 2 different mediums, e.g. by SMS and telephone. The majority of our work in triaging patients is telephone based. If we can't get through to patients after 3 attempts, then we cancel the referral and you would be notified they've not engaged with us. We would let you know when they start the program, so you're aware that the patient has started their behavioural support program. We would let you know if we cancel their program, and that is based on 3 consecutive non-attendances where they don't respond to us. So you don't need to worry about a patient having their program cancelled if they go away for a couple of weeks and then come back. If they don't engage with us for a prolonged period based on 3 missed attendances or a period of 3 months not using the digital product, the digital app, then we would notify you and then we would cancel their intervention. We also would tell you when they complete the program at the end. So you would know that they've done their 10 months of the intervention and finished it and hopefully made some really effective health changes alongside the Tirzepatide. There's an important note at the bottom here, which is that there is a chance that a patient will start the program with us and then drop out of their behavioural support for obesity prescribing program. You may still be seeing them as doing the clinical management of that patient and their Tirzepatide usage, and you might get a notification that we've cancelled their program. Now, it's up to you how you handle that as the prescriber. You might say, look, you need to do this. It's going to benefit you. We need you to go to behavioural support. Now, if you were to re-refer that patient, they would need to start from the beginning of the intervention again. There's a choice there. For example, they might drop out of face-to-face because their life's too busy, they've got too much going on, etc., and they want to try the digital program. So there's an opportunity there for people to get access to a new pathway, for example, one that works better for them. But patients can't drop out halfway through the program and restart at the point where they dropped out. They need to start from the beginning. And the final point on this kind of element, which I think is interesting, is that if patients, Richard mentioned in his presentation on adherence and discontinuation rates for the drugs, because we know there are some quite complex side effects through use of the drugs. If patients do drop out, they can continue on with their behavioural support program, particularly because we'd hope it would help them minimise any chance of putting that weight back on, which is obviously quite common when people do discontinue usage of the drugs. Cool, thank you. So at this point, I'm going to hand over to my colleagues, Bex and Chris, who are going to take you through some of the specifics of the BSOP program and how it differs to our NDPP program.
Yeah, thanks, Jimmy. So this, of course, was built out of the desire to deliver a program that supports behavioural change alongside the medication. I think Richard's eye-catching evidence earlier kind of shows the importance and value of that, but also shows the importance of us getting this right as well and offering that support in a way that's going to be really valuable to patients. Now, I always really like Richard's explanation of obesity and weight gain being a symptom rather than a cause, and it's unlikely that there is just one cause. Normally, it's a selection of many different factors that all intertwine and influence one another. So as part of our current DPP program, also we have a tier 2 weight management program, which has some similarities to this as well. Developed a real holistic approach that covers a wide range of contributing factors to potential ill health and of course with the aim of supporting an improvement in health, well-being and weight loss, almost seen as a byproduct of that. So don't expect you to be able to see everything on the slides here. This is just an example of just kind of showing the structure of the current program and the number of sessions that are delivered. This program will mirror the time frame of our current DPP program. So it will still cover that 300 days. There will still be the same number of contacts with the patients. So this was due to the need to develop this quite quickly, and NHS England's desire to start this with quite a quick turnaround. We have used our current DPP program as inspiration, really, and there are some parallels between our new program and our DPP program. However, it was incredibly important to adapt our current offering to make the course content more bespoke and suitable for patients that are currently taking Tirzepatide. So the next slide just going to show some of the key differences between our current DPP program content and the content specifically on this program. So next slide, please. Wonderful. So the text in blue are either new or adapted content, which is specific to this BSOP program, the Wraparound Care for Tirzepatide. Now, there is a little bit of a difference here in terms of the patients in session 1. This is more of a personal perception of this, I suppose, but for our tier 2 weight management program and also our DPP, as much as there may be some influence from a GP or from a medical professional, it is the client's choice to do the program, as much as that will be the case here. However, it's our understanding that it's a bit of a two-way street here from a patient's point of view. They can only have access to their medications for a sustained period of time alongside attendance of this behavioural support. So what that kind of means is that there's a likelihood that in that first session, there may be a few question marks from client point of view in regard to what to expect. Is it just going to be a hoop to jump through? And ultimately, one thing that's incredibly important for us in session 1 is to really highlight the importance of the behavioural support and the change of those habitual changes and those wider elements of lifestyle and contributing factors, and ultimately just hope that everyone leaves that first session with a sense of understanding and motivation, really, that there's going to be some real value attached to attending these sessions, and it's not just a hoop to jump through in order to continue the medication. Of course, referencing Richard's evidence from earlier really kind of highlights that. So the two main changes in the first session are just educating the patients a little bit on the specifics of how the medication can impact physiology and how the brain perceives things like hunger as well. So some expected changes, but specifically, how does this work into our bodies and how are we likely to experience that? But also really highlighting the importance of those wider, more holistic lifestyle changes to ultimately provide the most the best chance of a likely outcome, being not just weight loss and improved health for this 10-month program, but for steadily in the long term as well. Session number 2 focused on really introducing and emphasizing that long-term approach, but ultimately after a couple of weeks as a minimum of experiencing the medications, felt it was important to directly reference the importance of eating well and nutritionally dense foods, particularly with a reduced appetite, which is likely to be a side effect of the medications. So we've kind of rejigged and reshuffled some of the nutritional content to bring some of it slightly earlier in the program, but also added some more specific information relating to how hunger and fullness might be impacted and how we can potentially work alongside that to still create nutritionally dense and varied meals. And then also, excuse me, within the first month of the program, explaining a little bit in regard to potential side effects, but also understanding that there may well be some nutritional changes along the way in this first month or so. So part of it will be how can we maybe start to negate and tackle some of those symptoms with lifestyle, so with nutrition, activity, and other lifestyle factors, but also maybe just being really aware that are those side effects directly from the medication, or could they be from some of these other lifestyle changes that have been taking place, particularly if nutritional intake has dropped. So things like hypoglycemia could be a factor there. And I will be quiet for a moment now and let Bex finish off with the second half of this.
Thanks, Chris. Hi again, everyone. So yeah, kind of the next kind of part of the changes or adaptations that we've made kind of lie within kind of that that client or patient's kind of session 4 effectively. And the main kind of additions that we've made to this session kind of fall within the topic of protein. So really kind of introducing protein kind of generally, but then also kind of emphasizing the importance of meeting your protein needs while on Tirzepatide. And also kind of what that looks like practically as well, and also kind of including some kind of top tips in terms of how to meet your protein needs, especially with that reduced appetite as well. So a lot of like practical guidance in that session. In terms of the next session that looks at kind of movement and well-being, again, the main kind of additions or adaptations or emphasizing the kind of the addition of muscle loss that may happen whilst on the medications, but also how to reduce this risk with the addition or the inclusion of a bit of strength and resistance training as well, and also appreciating the fact that, you know, this can be quite daunting for these clients, so providing the right kind of guidance and kind of outside the content of their sessions, we behind the scenes have also kind of been developing and making sure that we've got enough resources and support to support in this area in terms of that specific guidance, and also how to engage in strength and resistance training in a safe way as well. The next session then, which looks at portions and meal planning. So the main kind of areas that we looked at adapting in this one was kind of learning how to meal plan, which can help kind of reduce skipping meals with that reduced appetite. So similar to kind of our core program, we've got a little bit of meal planning, but we've really kind of focused and honed in on the fact that we really don't want to be kind of under eating or skipping meals whilst on the medication, and what this can potentially lead to as well. So things like, again, coming back to your kind of protein, so not hitting your fiber and protein targets, that kind of loss of lean muscle mass, and that poor gut health, and also kind of leading to potentially kind of low mood, reduced immunity, and kind of hormone disruption as well. And again, kind of similar to our session on protein, just providing clients with that specific kind of real practical, easy way to introduce meal planning whilst on the medication, and again with that kind of reduced appetite as well. So things like guidance like, you know, aiming for a plate half of vegetables and a quarter of protein and a quarter of carbohydrate, things like including a portion of protein at every meal up to 3 times a day, things like including healthy fat sources, and kind of eating a variety of foods as well. So again, a lot of like practical guidance. We've also kind of adapted and tweaked the hydration session as well. So again, kind of emphasizing the importance of hydration while on the medications, and also how you can recognize signs of dehydration as well, coming back to our side effects, which comes earlier on in the session. Alongside the kind of the core content, we've also been making adaptations to our resources that we provide with clients as well. So each client on our kind of core DPP program gets a journal, and they get sent out kind of headliners post session. So we've been working hard in the background in terms of kind of adapting that content and making sure it aligns with this new format. Perfect. Next slide, please. Great. So yeah, I won't spend too long on this because I know, Jimmy, you spoke in quite good detail about this, but basically this kind of just kind of piggybacks onto what Jimmy said in terms of just making sure that our clients are aware of the 2 kind of areas of support. So our clinical support, which is obviously the kind of the provided by the prescriber or the clinician, and then kind of the behavioural support, which is that we're involved with, which kind of primarily involves kind of driving that sustainable lifestyle change through kind of our structured program, but also making sure that clients know both that kind of engagement in both elements is required to drive that long-term sustainable change, but also for practitioners, so we know when to refer back to the prescriber and clinician as well. So kind of knowing what's in our remit and when we need to kind of refer these clients back for additional support, like Jimmy said, in terms of kind of more kind of complex side effects or anything to do with like dosages or adjusting medications.
And just to finish off this section, really a lovely visual just to really highlight the more holistic nature of the program. So we tend to break down each of our topics and factors over the weeks into 5 sections. But what we find in reality as the weeks tick by is these all intertwine, but they also impact each other. Of course, nutrition and movement most likely being the factors that people are most likely to be aware of and focused on historically, and of course have a huge role to play in health and well-being, but are far from the only factors that have a role. So sleep, of course, being a huge one. Alcohol has a role to play, and then that psychological element of these underpins everything really. So just a quick example of that really would be sleep. So I'm not saying that we're going to be able to educate people on sleep and everyone's suddenly going to be able to have a beautiful 8 hours of rest every night and wake up feeling fantastic. But if there's anything that we can do to understand the patterns that are maybe holding people back from achieving better quality sleep than they're getting at the moment, whether that be managing to drop off slightly sooner, wake up one fewer time, get an extra hour here and there, the impact of that can be huge. But not only is that really helpful in the moment, how does that then impact the next day? How does that impact our nutrition? The hormonal changes that impact our hunger and our fullness, and also our motivation. How does that impact our movement? How does that impact how we feel? Similarly, if we do eat well, we are active, we are in a better mental state, how does that then impact our sleep? So these things often intertwine quite closely. And one thing that really links these together, which I forgot to mention in my last little section, which is one benefit that's also linked to tirzepatide is not only the suppression of hunger, but also the likelihood that what's been called and quoted as food noise to be suppressed. So this allows patients who maybe have got a history of a less than perfect and positive relationship with food, maybe allows us to delve a little deeper and a little bit more, I suppose, consistently and consciously into those non-hunger and emotionally related causes of eating and triggers in that regard. So yeah, ultimately just a nice visual to make all those words that are on the last couple of slides make a bit more sense, hopefully.
Cool, thanks, Chris. I think at this point I come back in. There were words on this slide, but they were hidden. But we'll jump through that one. So yeah, hopefully through that we've given a good update on what your patients would get access to through the behavioural support service, and the justification for it, effectively why it's necessary to drive success for patients who are prescribed tirzepatide in primary care. So I'm just going to touch on, I'm not going to spend a lot of time on eligibility at all really, because eligibility is quite heavily tied into the eligibility for prescribing, which hopefully people on this call will be aware of or become more aware of through their ICBs and local pathways. But also then I'll touch on how to refer, particularly if you've already started identifying patients in your ICBs or in your surgery, etc. So behavioural support for obesity prescribing is only accessible to those who are prescribed tirzepatide in primary care. The service we offer, so through Thrive Tribe, is only accessible to patients of our 7 contracted areas. So I listed those 7 ICBs at the start. 4 of them are represented here today. And if you have patients from that area, the only behavioural support for obesity prescribing service they can access would be Thrive Tribe. It's all tied into the NDPP contract. We had a couple of questions on this the other day when we did a similar webinar, one of which was what about if patients are paying privately? So, paying an online pharmacy or online retailer for their Tirzepatide. Can they access BSOP? Unfortunately not, because it's all tied into the prescriptions from primary care. If a patient stopped paying and taking it privately and they met the eligibility to be prescribed it in primary care, those patients could access this. But at the minute, it's tied to those who are eligible for prescription in primary care. One thing I would say on the behavioural support service that you might want to refer to or prescribe is we are funded at Thrive Tribe to run this in our 7 areas, but at the time of referral, if you as a prescriber, you see a patient and they are quite a complex audience and you go, well, I'm not sure that a 10-month group support program looking at behaviour change is the right circumstance for this. A good example might be a patient who is dealing with schizophrenia, they're taking clozapine, and that's caused them to put on a lot of weight. They meet all the eligibility criteria for this, but you might go, I don't think that the behavioural support offer is the right service for this. I'm going to refer them to the early intervention psychosis program or something like that as their behavioural support. You can use alternative pathways locally if they're provided. Different areas have different pathways, obviously. And the other bit with that is they need to be funded. Already existing places, the funding for behavioural support for obesity prescribing can't be used on other local schemes. There are some basic normal exclusion criteria. So, patients need to be over 18. They can't be pregnant or intending to get pregnant. They can't have an active eating disorder, etc. But for the most part, the eligibility for accessing the behavioural support for obesity prescribing program is what is tied to being prescribed Tirzepatide in primary care. Tilly, ready for the next one, please? So that is this. It's quite a tight cohort of patients initially, and I do think there is a chance it will get looser in future. So it's patients with a BMI of over 40, or where certain ethnicities apply, 37.5. We can provide the list of ethnicities should anyone like to see it. And then the patients must be living with 4 of 5 comorbidities. That's hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, and atherosclerotic cardiovascular disease. So 4 of those 5 comorbidities the patient must have and a BMI over 40 to be prescribed Tirzepatide through the new primary care service. And therefore, those patients that get that should get a behavioural support offer as well. And we would be the new behavioural support service for your areas. One point on that, it's been made very clear to us by NHS England, they don't expect Thrive Tribe on our behavioural support service to assess eligibility. The assessment of eligibility and searching for the patients that meet this criteria, inviting them in for an assessment on whether they would like and would benefit from Tirzepatide and then prescribing, that all happens on the prescriber side. And if they're prescribed it, they should get a referral to a behavioural support service, which is probably quite likely to be ours. We don't then assess eligibility. If a patient came over and their age was 15 on the referral form, or the referral form said they were pregnant, we would double check that with the prescriber and check that there's not a mistake, because those patients wouldn't be eligible. But if we got a referral with we're not going to be recording the comorbidities, for example. It's been made quite clear by NHS England that they don't want us marking the homework of the prescriber or the clinicians that are assessing whether someone's eligible for this. So how to refer, and there's slightly different models and different pathways across different areas, and also different ICBs are at different stages with this. We have started getting referrals. I think we're up to double figures now. They're all mainly from one ICB at the moment, and we have other ICBs who are coming on board quite soon. But local patient identification strategies and referral pathways differ. It depends on who is doing the prescribing and providing the clinical management. But there are consistencies. Any BSOP referrals, any wraparound care referrals to us should come through to healthier.unhs.net. That is a shared referral mailbox with our NDPP service. We have a central triage team. They will pick up all of those referrals and deal with them within a day or two. There is a bespoke Healthier You referral form for BSOP. There's a quick screenshot of it on the right hand side. It looks quite different to NDPP. It's obviously titled differently. It mentions explicitly the behavioural support in line with NHS England funding, etc. That's put together by NHS England. It's been slight tweaks to it in some areas, but that should be available via your clinical systems. So should you need to refer someone in your area, whether you're using System 1 or EMIS, you should be able to pre-populate that referral form and then email it to healthier.ua@nhs.net. We have started to get we have had some referrals on the NDPP form, but where it's clearly marked in the subject of the email that it's a wraparound care referral or a Tirzepatide referral, that's fine. They've been dealt with and they will be dealt with common sense and as Tirzepatide referrals, but where we can use the bespoke form, that'll be easier just to avoid any confusion between what is an NDPP referral and what is a Tirzepatide referral. I won't go into this in detail, but just to give everyone a quick note, there's a really big, long, took me hours, patient flow which is available and we can circulate to people should they wish to see it. This is just a very simplified view of it. So we get a referral from someone who has agreed to prescribe Tirzepatide to a patient in primary care. We process that referral within a day or two. The patient automatically receives a welcome email from us, which explains a little bit about who we are, and it mainly says that we will give them a call within a week or two. I'd like to improve that slightly so that we give them an option to book calls with us, but we need a steady flow of referrals to get to that point where we have dedicated telephone clinics where the patient can book. Regardless, within a week or so, we will call the patient and attempt to make contact with them. If we get through to them, we do what's called a discovery call, which is a 30-minute motivational interviewing sort of behaviour change phone call, on which we collect some data for NHS England, but we also assign the patient to a pathway. We either allow them to go down, we either refer them directly to our digital pathway through Second Nature, and they get an email from Second Nature and an SMS, set up their account and get started. If they would like to do either a face-to-face program in the community or a remote program run online, they get booked into that program on that phone call and they start at the appropriate date. At the bottom here, we've got the red boxes or the dark orange are when the patient doesn't respond to those phone calls. We try and contact them using a second method, which is either going to be SMS or email. If they're unresponsive or they decline, we cancel the referral and the prescriber is notified that they've not responded to us. Just some really high-level updates on the next slide, which is there are representatives of ICBs on here who've started referring, and we're working with other ICBs to get them ready to start referring. We've received the first few referrals. I think we might have hit double figures today, if not we're 1 or 2 off. Because of that, we've had a couple of people who have been referred to us have been waiting a couple of weeks. We are going to start our triage activity, start those phone calls to patients not tomorrow, Friday, sorry. I thought it was Thursday, but they're going to be starting on Friday. So we will be beginning to triage on this program by then. We have our initial online groups planned for mid-August. Bex and Chris, 2 of our most experienced practitioners and part of our clinical team, are going to be delivering those first 2 programs for us, with a Saturday planned for early September. So we could use a few more referrals to help populate those programs and make them a real success. And we will have a dedicated program lead for this at Thrive Tribe, who we've been doing some interviews for this morning. I've got 2 more this afternoon, and they will be in place to support the ongoing national rollout of this program when they come into post. I think that is it for our slides. We've run a minute over. I'm really sorry, everyone. But do throw any questions you have for us. So I'll answer one here. Put any other questions in chat, and if you need to leave, we'll circulate a kind of a Q&A document. But there's a good question here from Mir from Cornwall. Do we expect there to be a waiting list in future? So we got this question the other day, and I hope not. Effectively, we need more referrals at the minute. We're working with the ICBs to get areas live and get flow and throughput started. From our perspective at Thrive Tribe, we are only paid when people start the program, so it's not in our interest to have a waiting list. We want to keep the waiting list as minimal as possible and get people started on the intervention and going through it. So yeah, we've got vacant spaces on our first 2 programs that are running in August, and the sooner we can start to get referrals in to populate them, the better. We've got spaces. Should we get to a point where referrals are coming through like a waterfall and we're struggling to keep up, which might happen in future, I kind of somewhat hope it does, because we know that across our 7 ICBs there are in total 3,500 funded spaces on this program this year. Should we get to a point in October, November, or particularly January where it's coming through really fast paced, we would scale our resource to deal with that. We would put more triage resource in. Our project lead we're recruiting would tell me that they need more practitioner time, and we'd put that in post in advance. So there's a little bit of forecasting and pre-planning with this, but we want to avoid a waiting list. We only get paid when people are accessing and then achieving outcomes on an intervention. So that's what we'll be aiming for. There's another question here from Sarah in Southwest as well around completion rate for NDPP. So it's another good question. So what we only get paid for patient outcomes and attendance. The 95% of that payment for an individual patient is tied to their adherence. So how many sessions they attend throughout the program. So completion rate's a bit of an odd one because it works a little bit differently to our public health services. So, in our public health services, we have to achieve 9 out of 12 or 8 out of 12 sessions for someone to go and be a completer. It doesn't quite work like that for NDPP. It's about the percentage of sessions they attend between day 0 and day 100, day 100, 200, day 200, 300. But regardless, a big chunk of it is around people attending throughout. Our completion rate, so people that stick with the program to the very end, is equitable with all the other NDPP providers on a face-to-face and guided program delivered by Chris and Bex. That's about 40%. The completion rate of our digital program is slightly lower than the other digital provider that operates nationally. We're working with our subcontractor Second Nature to improve that, and they've got a plan designed to do that. So it's fairly equitable to the other providers. The big thing with this is that we and NHS England expect retention and adherence to the program to go beyond what it does on NDPP. The reality is, whether it's through the prescriber or us, it will be made quite clear that should the patient drop out, they need to restart from the beginning. They can't rejoin halfway through the program, and they should be attending a behavioural support program alongside their prescription. So we are expecting that to impact adherence and for it to be stronger than what we see on NDPP, regardless of some of the changes that we're making and the improvements that are making. Louise's question: program is 6 sessions over 16 weeks. Program is 10 months. What happens after week 16? So I'll jump in. Bex, Chris, if you want to follow up on this, feel free. But so there are 6 sessions in the first 16 weeks for sure, but the program is 10 months long. Effectively, there are 13 total sessions over 300 days. That's the structure we have to follow from NHS England. And the reason that those sessions were focused on the sessions that those 6 sessions were identified and Bex and Chris talked through the changes in content is because the majority of the changes in content from our regular NDPP program compared to our behavioural support for Tirzepatide program come in the first half of the intervention. There might be subtle changes to session 10 at day 240, which would be, I don't know, guess week, I don't know, my maths is awful, say week 30 for example. But there are less changes than in the first half of the program, which is what Bex and Chris ran through earlier. Bex, did you want to say anything?
Yes, Paul, apologies. Yeah, I've just realised I should have probably made that. We should probably make that clear why we kind of cut off. The text was very small, so we thought if we could just kind of screenshot where the changes lay, which, yeah, like Jimmy said, actually it's kind of the main ones are within the first kind of 6 sessions, and then beyond that it's very, very similar, if not the same as the core the core content. More than happy to kind of share that full overview of the curriculum in this chat.
Cool. Thanks, Bex. Excellent. Some good questions have come in right at the end there. Sorry we've overrun slightly. If there's any last minute questions anyone wants to drop in, then do put them in chat. We'll stick around for a couple minutes, even if other attendees don't. And should you get any questions that come in, or you think of any questions separately to that, drop us an email at hello@healthyeu, or give our central line there a call. That message will get triaged and escalated to either, whoever's best to reply out of Bex, Chris, Richard, or I. And we can respond to anything on there. Otherwise, it's been great speaking to you all. Hopefully that's been really useful information on the new program that we're setting up to support any patients that you do prescribe Tirzepatide. We're ready and awaiting more referrals. We've got spaces on our first programs, so yeah, really excited to get them going. Thank you everyone for joining.